No, it will be, yeah.
Okay, right. Okay, good evening, guys. Welcome from a nice sunny Belfast. It's horrendous here, red, and but we're getting very excited for St. Patrick's Day tomorrow. This is not Guinness. This is water. So
it will be tomorrow.
Hopefully, will be. So thank you, Chris, for coming on again. And we have two potential ultrasound students that are hopefully going to take their case accreditation soon. Well, I know they definitely will. So we've got Emily Haworth. Everyone knows Emily. Emily's originally from Ireland, but is practicing in Wales now. Has just completed her podiatric sports med and has been introduced hugely into ultrasound and is now going to take it to her case accreditation. As you know, Emily works in MSK and also uses ultrasound quite a bit in her high risk career as well. So interesting to hear what your plans are for that. And Tommy is a private practitioner in Southern Ireland. So Tommy again has got the ultrasound bug and is going to go the right way and do his case accreditation. And I believe you've been in touch with Chris at some stage as well. So thank you for coming on. So Chris, going to open the stage to yourself and take these virgin ultrasonographers on a student tour of ultrasonography.
Thanks, Sean. I think in our first podcast we covered quite a lot around competency, and I think we around storage of images, or we didn't get onto machines, which we can get onto today, because obviously that's we've just been talking about learning to play the guitar, and there's many comparisons between learning something like a musical instrument and scanning, because at the end of the day it is just a motor skill that you have to practice time and time again. But you can't learn how to play the guitar without a guitar, and if you buy a crap guitar, it's probably going to be a little bit harder than if you buy a really good guitar to start with. And it's exactly the same in ultrasound. You need to make sure that you've got the right equipment to do the job that you want to do. And certainly, if you do buy a cheaper machine to start with, then you're going to be compromised potentially with what you see, bearing in mind that you are going to be right at the beginning of your learning curve. So I always say, if you buy a crap machine and you're crap at the beginning, you're double crap, which is true, isn't it? Whereas if you spend out on a good machine, at least that gives you a bit of help. And then obviously we talked about competency, and myself and Emily were just talking there. There is, from my understanding, no guidelines at present that you guys as podiatrists can Google, look up and say, right, I need to do that. I need to do this many scans. I need to do this and that. And then as we said earlier, how do you then keep your competency, i.e. how do you maintain it and continue to prove your competency, which is really what this all comes down to. In physiotherapy, as we discussed yesterday, we do have sort of two guidelines that came out beginning of last year, I think. One around the use and the context of ultrasound for physiotherapists, i.e. how do we use it in our clinical in our clinics, which actually is quite a useful read. And then it talks about and it is only guidelines. This is not, as I said yesterday, there is no law out there. These are just guidelines, and they're a great start, the guidelines, but if you read them, you will still come away from it going, what do I do? Because it doesn't say you have to do this. It doesn't say you have to attend this sort of course. It actually, what it does say is that you need to do a course that is either case accredited or mapped to the equivalent of the case guidelines and competency and the HCP standards for people that are carrying out ultrasound. And actually, if you know nothing about case and you know nothing about ultrasound and you know nothing about mapping and that sort of thing, it almost makes it more confusing. But I think it's a really good start. I think Mike Smith was one of the guys that led on it, has done a really good start, and hopefully that document will evolve. So although it sounds like we've got it all sorted in physio, I can assure you we don't. Yeah. We have still got, hundreds of people scanning today in their clinics with a lack of supervision, unable to prove their competency, maybe on a pretty poor machine, not storing images and not writing reports. And we used the term ghost scans.
Yeah.
And if you just Google ghost scans BMUS, you'll get a very small but a useful document that explains really what these things are. So those are the concerns that we have as people teaching ultrasound. Obviously, we're trying to balance that up with absolutely loving ultrasound and wanting everybody that that everybody that is assessing MSK to be using ultrasound. And obviously, we teach loads of people, so you could argue we're part of the problem. And this is why I like doing things like this, because I think it's so important to try and get the right information out there
hugely
before people start, because there is one thing ultrasound does, is it spends your money, it takes up loads of your time and makes you more vulnerable to getting sued.
Very true.
That's it.
Yeah. Okay.
So is that worth it? I think it is, but it's only worth it if you are fully aware from the beginning, the commitment it takes to get good at it, the training that you need to take to do it, and the supervision, the support, the mentoring, the auditing, the PAC systems, the report writing, all of these things need to be considered. But if you are the person that, does an intro course, never records a scan, never writes a report, doesn't spend any time with other supervisors, all that sort of thing, then you're not embracing the way that ultrasound should be learnt and the way it should be used in clinic. Because if it's used correctly, it's awesome.
Absolutely.
But if you don't get to those standards and don't implement the right things, then it's dangerous, essentially. And it makes people like me that have spent a long time getting reasonably good at this, it makes me look bad, and it makes lots of people that are good look bad. And so we don't want that. We don't want radiologists saying, well, they're just all picking up the machine and not having training. And that's what some are saying. And we need to ensure that we're doing it the right way.
Which is fabulous. I mean, you sent me the documents from or the guidelines from physiotherapy, and that's one thing that I think we need as podiatrists. We need to set that up as guidelines. There's absolutely no doubt about that. And I know Jay, I think that's what they're working on.
They're definitely, Jay Saxelby, I spoke to him. It's definitely going to happen. I think what we underestimate as people maybe not so involved in these associations is the complexity around writing these guidelines. And it's not just that. You've got to think about, what do the radiologists think? So I don't know how it works, but I assume it goes to a group of radiologists, physios, case, and I can imagine it takes, I'm the sort of person, just write it and get it done. But these are, they're almost not parts of history. That sounds a bit much, but it is in a way a part of increasing or developing this area of it, which is still relatively new. So I think we have to be patient with it. And anybody starting out on ultrasound, I spend half my week speaking to people on the phone about, the classic thing, Sean, after I've done your 2-day course, am I competent? Can I charge for a scan? And at that point, I almost put my head in my hands, but it's not their fault, because this information is not easy to get. There are many complexities around it. And there's a lot of gray areas around it. No pun intended, obviously.
Exactly. So Emily and Tommy, just quickly, why do you want to go on this journey? I mean, it's tough. I mean, I must say, the PG cert I did in Bournemouth, it's not easy. It is tough going. And I mean, even the exams, I don't think I've done harder exams in my life in terms of the written exams weren't too bad, but the OSCEs were nerve-wracking. But it was, I'm glad I've got through it, and I'm amazed. And it's people like Chris and other pods, or other Abid or Adrian Berman, people like that really inspire me. And I mean, I would love to be even a percentage as good as them, But Emily, you've been introduced to ultrasound in your PM, your sports medicine. So why do you want to take it further? Is there a reason? And I'll ask you first, and then we'll ask Tommy. And then
I was about to say, listening to Chris, listening to Chris there, I'll just take my headphones off and walk away. I know the step ahead is going to be really, really tough, and I'm actually terrified of Case and going ahead with it. I know it's going to take over my life for the next year completely, and then beyond. And then, as I realised after finishing QMUL, the hard work starts then. It's not just the PG cert and everything, and cramming for exams and OSCEs, and it was tough. It was very tough. The work starts after that, and building up on the skills learned and things. And Case accreditation, I think, will be the same thing. So it's going to be a very, very tough year ahead, and then the journey starts from there, and the hard work starts from there. I guess QMUL, we did quite a lot of diagnostic ultrasound. I was there for that week on site, and Chris was lecturing there, and you kind of inspired me, Chris, with huge energy when you walked in that room and barking orders at all of us. And we had like a full week almost of immersion into it, which was it's very rare you get that, really. You know, you're working full time, and to have that luxury of having immersion into full study for that week was brilliant. I was kind of jealous of everybody doing full time there, but that wasn't an option for me. So I think those 50 hours we got of immersion into ultrasound kind of was superb. But you realize what you didn't know after that. And the more you learned, the less you knew, if that makes sense. So coming out of that week, I thought I know nothing about diagnostic ultrasound whatsoever. And my anatomy is still weak, you know. So I think that inspires me. I love the thought that you'll never, ever know everything about it, and that it'll be a continual learning process for the rest of my career. I really like that.
That's really interesting, and I think you nailed it there. We talked about this yesterday, Sean. The scary part of all of this is the clinician that doesn't know what they don't know. Yeah. And you have to discover that. And a bit like when you say, Sean, I'm sort of getting it. Yeah. And actually, to a lot of other people, they probably think you've got it. Yeah. But we know that you never get it. Never. You just have to keep learning. The machines are getting better. You're seeing more. But more important than that, a Morton's neuroma or a bursite, they don't look the same as each other always. There's so many different presentations, and every patient is slightly different. Yes. And we love putting people into a box, don't we? You've got a Morton's neuroma, you've got an MTP joint art. Well, actually, they might have a bit of this, a bit of a degenerative plantar plate, a bit of, and it makes you question what you do. That's wonderful. But it really makes you realize clinically and diagnostically how limited we are. Yeah, absolutely. That doesn't mean you can't successfully treat people without ultrasound. Of course you can. But actually, if you've got an ultrasound machine and you're good at it, you may as well use it, because you are going to gain more information. Absolutely. But yeah. It's good. Tommy, I know, there's been quite a bit of debate in some of the Facebook pages on whether you should or shouldn't continue and do your case. There's some weak arguments, and some people have put together some quite strong arguments, but you've obviously decided to do case, and you've obviously decided to sort of get yourself in the ultrasound. So chat about it, go ahead.
Over the last, 2 years, like really since COVID started, I've taken a bit of an interest in ultrasound, and I've done a couple of introductory courses at this stage. And as you rightly said, they're just on the likes of Facebook forums and stuff like that. The water is just so muddy around litigation and stuff like that. And I think the reason I want to go ahead with the likes of PG cert is, it's a form of qualification. And when it comes to the likes of, a court case or something like that, at least you have that piece of paper that says, you've committed to the training, you've done X, Y, and Z, and a minimum standard, I suppose. Like yourself, there's lots of other practitioners out there at the minute that are scanning away, injecting away, using it to guide diagnosis, but they're not reporting and stuff like that. I think if I'm going to invest in an ultrasound machine and start using it, I want to have the ability to be able to write reports and perhaps make some sort of an income from it as well. At the minute, like as I said, I've done quite a few introductory courses, 2 days here, 2 days there, some online stuff with Celtic SMR and stuff like that. But I haven't a clue. Like, you know, like I genuinely don't. And I read quite a few papers and bits and pieces around the sort of physics of ultrasound and stuff as well. And like, it's a minefield, but it's an exciting minefield. And I think, you know, eventually when you go through some formal training and you get the hang of using the machines, I think ultimately it's going to bring my MSK practice to another level.
Absolutely.
I just feel like, you know, I started injecting in the last couple of years myself, but all the injections I do are blind, you know, and they seem to get okay results, but there's no way of knowing what you're injecting or whatever without you know, some sort of imaging. And quite often the likes of neuromas and stuff like that, I'd send them on for MRI to confirm diagnosis before or some sort of imaging before committing to an injection, you know. Yeah, so I think that's a big part of why I want to go ahead with it, is to get, you know, have the ability to scan real time in clinic and make, you know, clinical decisions from there. The PG cert, as I said, you know, I agree with yourself, it should be minimum standard, you know, have some sort of minimum standard, some sort of minimum guidelines that we have to adhere to, you know. I think that's important.
Yeah.
You won't send for an MRI when you get good at ultrasound, because ultrasound's so much better than MRI for looking for neuromas.
I had a girl in my clinic there last week, the week before, suspected had an MRI. I had suspected had interdigital neuroma, so I sent her off for an MRI, and the MRI has come back today. The MRI results show, you know, states on the MRI report 3-4 times no neuroma, but they have diagnosed it as bursitis, you know, interdigital bursitis. And I'm thinking to myself, like, you know, they both come hand in hand often, you know.
They quite often do. You can have bursitis without a neuroma, but normally they go hand in hand. But I work closely with foot and ankle surgeons. They don't bother sending for an MRI anymore. They'll just send to us for an ultrasound.
This lady had all the clinical symptoms of Morton's neuroma, you know, positive Mulder's click, the numbness and tingling type sensation, more painful in shoes, feels like walking on a marble. Like, I was 100% sure she has a neuroma before sending for imaging, and now the MRI has come back and said no, it's not. So,
and an MRI, honestly, we get so many MRIs double reported, and they come back with different reports. Like, MRI is operator dependent. Ultrasound is obviously operator dependent.
Yeah,
but we give MRI. Okay, MRI is not gold standard.
Yes.
For lots of things you're seeing in the foot, it misses loads of things: calcifications, small neuromas, avulsion fractures, bifurcate ligament. Like, all these things are not seen on X-ray, and sometimes not even seen on MRI. MRI is not great at picking up small calcifications, but we all go MRI normal. It's not there.
Yeah.
It doesn't work like that. If it's brown and it looks like a twig, it's a twig.
Yeah.
Until proven totally otherwise. Do you know what I mean?
Yes, exactly.
I've had people go in and the surgeons looked in and gone, yeah, there was a neuroma.
Yeah, I've seen that before.
Yeah.
So that's great, Tommy. Thank you, Chris. Take these. You've got two nice victims online here. Take them on the journey of the newer course. What do they expect? What do they expect afterwards? And scare them to death like it did me yesterday. Of the grad, which would after you qualify, what should be doing as well.
So just a couple of terms are being thrown around. So let's just be clear. So CASE is the Consortium of Accredited Sonographer Education. So they're an organization that has been around a long time and was in charge of accrediting education pathways. I think generally, you know, higher education institute pathways, to say that your course is satisfying all the standards and it's mapped against their standards of education for somebody doing ultrasound. That's great. That was for sonographers. Okay. Where CASE, to be fair, has had to adapt is that there are many people now that are not sonographers like us scanning. Do we use ultrasound different to a sonographer? We really do. And in fact, we are not insured to work as a sonographer. We're insured to work as a pod or a physio who carries out a clinical assessment to support, prove, disprove the hypothesis. Okay. Now, Case have now got physios on board, pods on board, like Jay and Stuart and that, to help guide what they're doing. Now, I've just been through, so we ran a PG cert very successfully for 2-3 years without Case. So it's, when I say without Case, to get this course through a university is hard.
Yeah.
So everything is mapped against different standards. Okay. And we thought, let's see how we go. All of our cohorts have been full, but we got to a point where we thought, do you know what, to future-proof this course and make it even better, let's go through a Case accreditation process. So we've done all our paperwork for that last week. We've got a Case event coming up in May, and then hopefully, fingers crossed, September, we get accreditation for that. So the reason I'm just going through that is even when I'm mapping it against our course, I'm looking at it going, that's not how we use ultrasound.
Yeah.
You know, we do a clinical assessment and that sort of thing. And that's no, I'm not criticizing Case. I think they do a very good job. And actually, we've been through that mapping process. And I can assure you that our course is getting even better because of it, more robust. So that's a really good thing. The key thing to remember is, and you said it, Tommy, is we are talking about a postgraduate certificate, Case accredited, to get you to a basic level of competency, the minimal standards. It's like coming out of pod school, podiatry school. You're crap. You're rubbish. And then my issue a lot of the time is now we've got to sort out the educational side of it. So how do we get to that level of competency? But actually, what are we doing afterwards? And ultrasound is such a, this is imaging. This is looking inside people's bodies. How do we all know that everybody that's scanning has the right standard and is keeping their standard and is storing their images, writing their reports, spending time with other people, auditing their scans? And at SMUG, we're developing an auditing tool that, you know, the more I look at it, and we were almost finished it, I'm like, this is exactly what people need. So the postgraduate certificate is generally broken into 2 modules. Okay, so you've got module 1, and that, Tommy, goes through all of your physics. Okay, and every standard for ultrasound you have to be able to prove that you've been through the physics of the machine, because it is really important. And the problem with introduction courses, and I run introduction courses, it is an introduction, and both of you have done quite a few, and I think you've realized you've enjoyed it. You've dipped your toe, but this is not a pathway for learning ultrasound. It's an attendance only certificate. What does that mean? Actually, it does mean something. It means that you can show you've been on a course, but in no way, shape or form does it prove your competency. So the module 1 goes through the physics, etc., and then we concentrate on scanning and normal anatomy. So we break the podiatry course. The podiatry course, the first 2 days, which I'm really excited about doing, is taught with physios, sports doctors, because you guys need to integrate better.
Yeah. And
ultrasound will do that. And we purposely did that to ensure that you're getting the physics, you're getting the normal anatomy, and you're getting the foot and ankle bits of it, the first basic bits of it, with the physios, with the sports doctors, with the radiologists, with orthopedic surgeons, all the other guys doing the overall course. And then in module 1, we split that down. The other guys go off and do, for example, the shoulder and different areas. And then what's going to be amazing about podiatry is we've then just broken it down into calf, Achilles, rear foot, midfoot, forefoot, and the dorsum of the foot with those bits. So you're going to have like a really detailed look at all of those regions. And honestly, guys, you've got it easy. You're literally having to learn about one bit of the bloody anatomy. So, you are using it, and this is important, you're using it more as a focused tool towards one area. So your learning pathway, in theory, should be slightly faster than, you know, that doesn't mean foot's easy. It's really hard. And if you get a decent machine, it makes it even harder because you see things you didn't even know you could see. So we break it down and then we concentrate on normal anatomy. And we were saying this yesterday, Sean, or whenever it was, you know, was it yesterday?
Yeah, it was yesterday.
It's been a long day.
Yeah.
I've been teaching all day as well. So concentrate on normal anatomy. Concentrate on the spectrum of normal, scanning your family, scanning your friends, scanning your favorite patient. And, you know, if you want to know how to implement that into your practice, watch the previous podcast. And we went through that in quite a lot of detail. And then we do an OSCE in December and you have to prove to, so you'll be nervous for that one, Sean, although you've been through it now, but Emily and Tommy, you'll be nervous for that one. And I like a bit of nerves, so I don't make you feel easy about it. And then I smile at you at the end, so it's all fine. But and then you just have to go, right, we have very simple cases. Can you scan this person with forefoot pain? And we would expect you to go through normal anatomy. So there's your plantar plate, there's your tendons, there's your bone. This is where I'd expect to see a neuroma. Okay, well, how would you look for that further? Well, I do a dynamic assessment. Would you look from the top or the bottom? Well, some people think it's better from the top. Actually, you just get used to what you're good at, etc., etc. So you do that, and then you pass that, and you do a case study in module 1. So that will be, you choose one of your cases and you talk around lots of different things, pros and cons of ultrasound. What's it good for in that case? What's it not good for? What information does it give you? What information doesn't it give you? You know, what other imaging do you need? And then you can look at interventions a bit as well. So although we don't do injections per se, we talk about them. You know, I can't help but show you how I do my injection for a neuroma if I'm showing you a neuroma. So, and then you, in January, you start module 2. Module 2 is basically, and this is probably, Tommy and Emily, something worth us talking about, is this is where you have to get your 250 scans and you need a clinical supervisor. And that is obviously where lots of people struggle to be able to complete a PG cert. And this is where we were saying yesterday, Sean, well, what about if people can't get a clinical supervisor? Are we saying that's it, they can't scan? Well, there's an argument to say they shouldn't scan because they're never going to get good at it. Or are there other ways of learning through informal competency pathways? But to be honest, the Royal College may not accept that in 2 years if their guidelines come out. So, Tommy, you said to it, get that bit of paper, do it the right way, do it properly. I can't disagree with that. But obviously for people that struggle with supervision, it's difficult. Once you've got your PG cert, you are okay. You're probably quite good at normal anatomy, but you've got no idea of the spectrum of pathology and what every pathology looks like. So once you've qualified, you are still defining your scope of practice through your logged scans that you continue with the reports you do, with the storage of images that we talked about yesterday. And you need, I always imagine somebody says, you missed that, you're terrible, I'm going to sue you. And I just imagine having a big clump of paper and going, good luck, because you've got all of this documentation, which continues after your postgraduate certificate.
Yeah.
And your audit. So, you know, how are you auditing your scans? You know, because the British Medical Ultrasound Society say 5% of your yearly scans should be audited. I can guarantee you most of your pods haven't had one scan audited since they picked up their ultrasound machine, unless they're in and I'm talking not just about private practice here. I've worked in the NHS, I teach in the NHS. I rarely find a local guideline in the NHS about who can scan, when can you inject, what is the minimal competency level, who's doing audited scans, who's not. It's not out there. It's very, very rare. So yeah, so that's the sort of my round trip of scanning. And if I put people off, I've done my job.
Do you want to leave now, Tommy and Emily? I'll pop you now.
Yeah.
Have you any questions? Go ahead. Ask Chris some questions. Emily, any questions?
I'm my obviously my background, Chris, as well, has been limb salvage and high risk for almost 20 years before I moved into MSK. And my kind of raison d'etre in my career is to merge the two together, high risk and MSK. I think there's a huge value in doing both of that. Do you see a role of Diagnostic US into the high risk foot area?
From a vascular point of view.
Vascular and other point of view, early detection of Charcot-arthropathy is one area. I think there's some research being done on it. It's skirty, there's not a lot on it, and I'd love to see this developed into that area.
I mean, so one thing you have to know about is scope of practice, as I've just said. If I started to answer that question, I'd be completely out of my scope of practice. So that's what I would say. However, I'll give you a couple of opinions around it. So the first thing is, what's amazing about ultrasound is it is now being used for things that it was never used for. From a cardiologist to obs and gynae physio, women's health physios, to lung respiratory physios, this point of care ultrasound is being used and the role is developing. And it sounds like, Emily, that will be one of the roles that ultrasound will be developed into at point of care. In terms of vascularity, there's pretty much that, well, there are better things, but there's nothing better at seeing small vessels. But you look at the new Canon machine, they've got, what do they call it? SMA, super microvascularizer. I don't know what it's called. So you're seeing really, really, really small or lack of vascularity to the point you don't actually know what's normal. It could be normal. But yeah, I see a massive role for it, but totally out of my, and this is where you can start. You'll probably be one of the first people to really look into it, Emily.
Absolutely.
I believe
There's
so.
no doubt that you see the vessels beautifully, and I'm sure you'll be asking questions like, oh, hang on, if I can see that there, well, can I do something with that? Or could I monitor it? Or could I do I don't know, in terms of joints, remember you see the joints beautifully. And so you should be able to potentially follow it. I don't know. Again, I'm going out of my scope here, but I can see a huge role for it.
Fab. Tommy, any questions?
Not a lot, really. No. Yeah, I suppose for me, with the whole just going back to the minimum standard and stuff and scanning normal, like the reason I haven't picked up a scanner as of yet to do any scanning in clinic on my own is just for a fear of missing something. So for me, it's more about what I don't see. Like I would be happy enough, picking up a scanner, scanning the first MTPJ and guiding an injection. I think that's something I could probably do. But for me, and a big part of the reason why I haven't is just that fear of missing something more sinister while focusing on, say, for example, a joint or a neuroma or something like that. And that's another reason why I feel it's important to do a good level of, minimum training, I suppose.
Have you got a machine, Tommy?
No, I don't. No, I'm in the process. I'm looking, but I'm going to try and spend as much as I can to get a good quality machine instead of, I'd rather buy good, buy once sort of thing.
Yeah. No, we said that yesterday. Buy cheap, buy twice. Tommy, first of all, you're clearly a conscientious practitioner. You don't sound very gun-ho. And there are pros and cons to that. Okay.
Yeah.
Because if you don't pick up the guitar, you can't learn to play the guitar.
Yes.
But don't pick up the guitar, put yourself on a stage and start playing with a band.
Yeah.
So don't worry about patience for now. Get the machine as soon as possible, because if you're starting a PG cert in September, you do not want to be putting a probe for the first time in September.
Yes. Yeah.
So take the machine home, scan yourself, scan normals. We've got the Smug YouTube channel. We've got 2-minute videos for pretty much everything, the basics you need, and sit there and scan yourself. Scan your family, scan your friends, scan your favorite patient. Obviously, let them know you don't know what you're doing. So, start with you, but you've got to start, Tommy. So sometimes this sounds, some of the guys I've seen really develop quickly are the ones that I would say are sort of borderline gun-ho unsafe. but
Okay.
they are putting the probe on people.
Mm.
The key thing is to know is this is actually really key, is you need to look at your referral pathways, because you will find things, and Sean will tell you that feeling of, have I missed something,
Oh, yeah.
doesn't go away. Done it 15
Yeah.
years. You're still, I worry less, but every now and then I'm like, what is that? And you'll see, and sure, you guys will see, I post on the Facebook group,
Yeah.
and
Yeah.
I send WhatsApps to the best guys I know and saying, what do you think of that? And the best guys I know go, I don't know.
Mhm.
So you can't know everything. I'm talking about the best in the world that teach all around the world. And
Yes.
so if you think you know it all, first of all, you don't, but you're not in that position. But Tommy, my biggest bit of advice is get scanning,
Yeah. Yeah.
but in a safe environment. Get the guitar, pick it up, close all the doors and strum away to yourself.
Yeah. Yeah.
That's how you get started.
That's fabulous advice, really is.
Right,
There you go, Tommy.
yeah.
No holiday for you and the family this year. You
Yeah, yeah.
ultrasound.
Next,
And the other
next-
thing,
and
sorry,
the-
Tommy, go on.
The guys are. I'm doing some training with Sean and some of the guys next week. So
Mm.
I think some of the manufacturers and machines are going to be there. Is that right, Sean?
I'm not too sure, actually.
Yeah.
Um,
Well, I hope
Gareth
you've got some
Clare.
machines, Sean.
Yeah, what's that?
I said, I hope you've got some machines.
I think Gareth and Clare are sort of organising that. I'm coming up at
Yeah.
some point just to maybe help out, but I think they're. I honestly don't know what Gareth has organised for that now, to be honest.
Yeah,
The more you can practice, the better. There's no
Yeah.
doubt about it. But you need you need people like Sean going, it's not like that. It's like that.
Mhm.
Yeah.
And that little thing is, you have to have supervised practice. And just so you're aware, if you can't prove you've had supervised practice, you haven't had it. So you've got to document stuff, even if it's just a simple bit of paper. But if people are out there not spending time watching other people, getting together like Sean does, he's got a little group of ultrasound buddies. I have the same. You get together, you scan a bit, you document it. That's how you're going to prove your competency. If you're not spending time with other people and not getting some supervised practice, which obviously you have to do for the PG cert, but even after that, then you're going into that thing where you do it. It's like if nobody listens to you play the guitar, you could play that chord wrong 20 times.
That's true.
And they go, that's not quite right. And then they go, just do it like that. And they go, oh, that's much better. And so you've got to get that supervised practice as well. And that's the hard bit. So Tommy, Emily, how have you gone about getting supervised stuff? And you may not have sorted it yet, but what's your challenges around that?
I've got there's a radiologist group in the NHS where I work, and they are very pro
Wow.
physio and podiatry.
Brilliant.
And one of the Band 8 physios set up a group with myself in, himself, 2 radiologists and a TNO, where we're going to bring scans in, and the radiologists will peer review those and actually bring the patient in as well. So the radiologists will rescan for us while we're there.
Perfect.
And so we've got that set up and ready to go.
That's brilliant. That's
And
superb.
that's important, Emily. First of all, everybody that's watching this is sitting there going, like, they're jealous. Like, you've got the setup that everybody wants.
Absolutely.
Just to be clear on the PG cert, I get this question a lot. 100 supervised scans. So a supervised scan is somebody watching you scan and going, that's good, Emily, but when you do that, do that. And when you do that, do that. And actually and they're supervising you and you write your report. They don't then have to scan it. They don't have to, you could be completely wrong on your supervised report in theory, because actually you couldn't be, because somebody's watching you scan. So actually forget that. It's a supervised scan, somebody's over your shoulder, and as you get better, they're giving less input. The unsupervised ideally is what you've got. The patient comes in, you scan, write your report, away from you and your report, so they're blind. They scan, write your report, and then you look for discrepancies. That is the perfect setup. Now, there are lots of people that do not have that setup. and but you do need to try and make that happen. So it isn't a question. The other thing, like, people go, they come on the PG Cert and they go, yeah, I'm going to do it with them. Do what with them? Well, I'm just going to go and watch their lists. And I'm like, no. So definitely watch their lists, but you've got to get your hands on and scan those patients. So that's, and then you've got your 150 unsupervised, which will be audited against the person that's scanning.
That's a super setup, Emily. You're lucky, lady.
Yeah, very lucky.
Because I remember I had to get in touch with a couple of, well, I was lucky enough, I'm quite friendly with an orthopedic surgeon. He introduced me to an MSK radiologist. And then Gareth and Claire, who I trained with as well. Claire had a contact with a sports med consultant, and he was fabulous. He come up to us, we went down to him, and then I spent some time in with the MSK radiologist. But I mean, they were amazing, absolutely fabulous guys, and they were very pro podiatry and they really wanted us to learn, and they were tough. They were tough on us too, you know, especially Alan Rankin, the doc. He, my God, I really did feel like a first year student again with him, which is probably great because it really pushed me. You know,
you couldn't,
as Chris
you had
was
to
saying,
practice, Sean, didn't you? You had to do your work in between, otherwise you turn up, you know, looking like a brat.
And even how I was holding the probe, even how I was sitting, even your sitting position is so important, Tommy. You know, I mean, that's all strange, you know, where you're looking to your left, and you know, it really was, it was so new, but I mean, it's worthwhile, and the mentoring, you will learn so much if you got a good mentor. There's no doubt about that. And Emily, you're lucky. You've got some really high class people involved there, so you'll be the jealous. Everyone will be jealous of you in your class. There's no doubt.
I was the first podiatrist within the trust to do it, and I've got some great physiotherapy therapists who are already scanning there and who are like really supportive of me. So yeah, I'm very lucky as well.
Yeah,
and then the radiology team as well.
Just close to you as well in Wales. I just saw there's another pod who just got consultant status there, Gavin.
Gavin, yeah, no, it's great. It's great to see. He's been scanning for quite a while.
So, I mean, he's just around the corner from you.
Yeah,
amazing.
Yeah.
So Tommy,
the other thing,
start talking numbers to get you scanning here.
Absolutely.
I mean,
but as I put this off for so long, like I mean, I think it must be 3 years since I've done my first introductory course, and like I've gone over and over it, and I was like, am I, you know, capable of actually doing this with, like, I run my own business. I'm there on my own, you know, so I don't have staff. So it's like, it's a huge commitment for me, not even financially. Financially is one side of it, but for me, a time commitment, managing time to do the scans, do the supervision, you know, organize all that stuff, run a practice, and spend some time with family. You know, I think, you know, I think now is a good time for me to get going at it. I really do think, and I'm under no illusion. Like I know this is not going to be an easy journey, but you know, like, I mean, you put your mind to it, I do it. You know, I think that's
absolutely.
That's the hard.
If it was easy,
everyone
wouldn't be doing this podcast.
Yeah.
Because if you think about ultrasound at the moment, it's a pyramid, isn't it? You've got lots of people doing the intro courses, you know, and then there's people dropping out on the way because obviously family, business, not having access to an ultrasound, you know, not getting the right clients in. And then, and it's very satisfying when you start getting really good at this, because I know it sounds a bit cheesy, but nobody can take that skill away from you once you've got it, or once you're to a certain level. And that's pretty cool. And what's also cool is every day of your working life, you're looking inside the human body. That's really cool. And after 15 years, I still think it's so cool.
It's amazing, and patients love it.
Yeah, oh, absolutely. Patients love it. I think for us as a podiatrist, it, like, you know, how many people actually know what a podiatrist does? Maybe more and more now. But like, from a professional standpoint, I think it just, as you said, it impresses patients, and not that's the reason for doing it, but I think it sort of raises our level of professionalism. But just like injecting does, you know, like, I mean, you talk to patients all the time. Oh, I didn't know you could do injections. Oh, I didn't know you treated, you know, knee pain or stuff like that. I thought you cut or percussion.
It's a really good thing for the profession. I totally agree. And You know, we got foot and ankle surgeons. They come on our courses. I've taught a whole group of them up in Newcastle a couple of years back. You know, and they're trying to learn exactly what you're learning, which is the diagnosis and guided injections. So it definitely is. But this is why we've done this, really, is to say, look, this is a really good opportunity, you know, and don't mess it up for everybody else.
It's brilliant. Chris, it's absolutely flown. We're nearly an hour up. So we've got about another 6 minutes. I'm going to leave the last 6 minutes to you. Right, wish list. I have a Sonoscape X5, which cost me, I don't know, 15, 16K. Right. So what do you think is a sort of a decent machine, in your professional opinion, that would be good for these guys who maybe invest in? And if they won the Euro Millions tomorrow, what would be your ultimate machine that you would want?
I'll start with the first one. I'd go for a GE E10.
Okay.
Logic E10.
Okay.
You need 50 to 70 grand for it. But I promise you, I'm good at ultrasound.
Yeah.
It makes me better though.
Yeah.
I see more. It's what I want to use. We use it on the courses. Like, I want that machine. I have a Logic I have many Logic GE Logic machines, R8s. That's going to come in at around 15 plus VAT, something like that. I think you've got to reach for that. This is, and this is going to sound a bit stupid, but if you can't afford that, or you don't want to prioritize what you're trying to achieve, you know, it's a lot of money, don't get me wrong. Either just delay it and do it when you can, or bite the bullet. Don't bother buying a shockwave machine. There you go. Yeah. Why don't you get the diagnosis right in the first place before you decide and what you're actually going to treat it with?
That's good. I like that. Yeah.
Yeah. And the other thing as well, Sean. So you spent about that 15 grand.
Yeah.
Just to be clear, there are machines, handheld machines. Okay. This is the one we get all the time. Should I buy a Clarius? Should I buy a Vscan Air? They are amazing machines for 3 to 4 grand. Okay. They're amazing, but they're not, they're amazing machines for 3 to 4 grand. They're not amazing machines. Okay. And so you can start with it. I wouldn't let anybody in my clinic, across all 5 clinics, scan with that machine. They're more likely to make an error.
Okay.
I also not convinced in a clinic setting how professional it looks.
Yeah, I was going to say that. I totally agree. I totally agree there. I think if coming into a clinic, especially if you're going to pay for a scan or pay extra for an assessment that includes a scan, picking up a small handheld device that connects to an iPhone. No.
If you want to see if there's an aortic aneurysm and you're running into A&E, amazing. But we're not doing that. We are looking at the smallest things under ultrasound: 2 millimeter tears, 3 millimeter neuromas, a little bit of a tear in the plantar plate. You haven't got a chance on the plantar plate or a neuroma with any of those cheaper machines.
Yeah,
you'll see a massive one and you'll miss 80%. I promise you.
Yeah, it seems to be focusing on the aesthetic injection market an awful lot. That's who they're aiming at,
The reason I say sometimes, I've got somebody on our mentorship program at the moment, and they've got quite poor access to a machine, like 1.5 days a week. So she's actually bought a Clarius. She's bought a Vscan Air to just use at home and do a little bit of this and that. And she'll probably sell it for only $1,000 less in a year's time, but she's doing this PG Cert mentorship. And I'm like, you need access now. So she's like, well, I'll buy that and then do that. So look, these machines are amazing for that price, but the more you spend, the more likely you are to not miss a neuroma. And there is no deal out there. So if somebody's saying this is an amazing deal, it is done on the quality of the image. You spend more, you get a better quality of image. You're less likely to make the wrong diagnosis. Radiologists would laugh at us scanning on a handheld machine. It's laughable. They would never do it. So why should we do it?
Exactly. That's perfect. That's great. Well, listen, we're almost at the end of our hour. So listen, I'm just going to put this to the students. Emily and Tommy, is there any, you've got this man, you may as well take his time here. Any questions you want to ask? Emily?
No, he's scared me enough now for ready for September. I'm Frankly terrified. No, I'm really looking
No,
forward
you're
to
not.
it. I'm looking forward to the challenge. I'm
Yeah.
relating it to Tommy, to like QMUL, which was the most fascinating year, but it was also hell. Trying to fit in the time and just the constant study all the time. So I'm preparing myself for that ahead again. Yeah.
You've got to put
Mental.
time aside when you're committing to spending a lot of money on these things. Make sure you give it the right time and make sure the timing is right. Like Tommy was saying 2 years ago, you got young kids, it's never going to happen.
Yeah.
But maybe the timing is a bit better now. And if the timing's not right, don't try and force it in. Just wait. It will still be there the next year.
Tommy, go ahead. Anything you want to add?
No, just much the same as Emily. Like, I'm excited, but a little bit worried about the workload to come with it as well. But I think ultimately, as I mentioned earlier, I think it's something that we should all be doing. And I can see how it's going to add to my practice. I think while it is a lot of money and it's a massive time commitment, you could spend the money on latest and greatest, therapeutic machine, shockwave, laser, all the rest of it. But I think ultimately, when you spend the time and the money on doing the training, I think ultimately that'll pay back tenfold over time. So I'm ready to throw myself into it at the deep end. And
absolutely invest in yourself. Isn't that what they say?
That's it.
Push yourself. Live the regret. Push yourself all the way. That's what I say. I mean, I'm a dinosaur now, but I'm still thinking of doing more post grad. But listen, I must say, in the years I've done it, I'm loving it, and I'm still learning every day. It's a school day every day, and I welcome to the group. You're going to love it. You really are. And I mean, you're going to go to college with this man. I think you'll be way above everybody else. I mean, think of the experience that this man has, and his passion and enthusiasm, and his fabulous teaching ability. You're really going to be coming out hugely on top. So well done.
The other thing that we try and do with Smug is, yes, come and do our PG Cert, but it doesn't stop there. We run so many different courses, and we are trying to develop lots of things that will be coming out in a few months around auditing, around mentorship, around our YouTube channel. So there is quite a good supportive network, and as most of you know, we have a Smug Facebook ultrasound forum that anyone can join, and I'm fascinated. I mean, I think there's been 3 scans put up today, and it's just a great forum to learn from, and from very like-minded individuals that are clearly trying to push their, we're not bored with our careers. I think you can tell, both me and Sean, and same from speaking to you guys, we want to just keep pushing on and keep that whole lifelong learning and keep us interested. That's probably what we're all doing.
Well, that's great. Well, listen, guys, thanks a lot for coming on. Thanks, Tommy. Thanks, Emily. Thanks, Chris.
Thanks, guys.
Recording will go live soon, and we'll put it out to, again, all the usual social media platforms. And Chris, let's do this again.
Brilliant. Cheers. Enjoyed it.
It would be fantastic, Emily and Tommy, maybe during your training. Why don't we do some live Zooms of you actually training, and you can talk about how things are going and stuff like that? That would be really good. Keep this going. I think this is a fabulous forum for other people on. So I really think we should keep this going. This is tremendous.
Yeah, let's follow it up in November when they're cramming in for their OSCE.
Absolutely.
Cheers, guys.
Thank you, guys. All the best.
Thank you.
Happy St. Patrick's Day. Look after yourselves.
Okay, good luck.
Bye.